to present it as an abstract or present it as an article in the journal is not easy. It needs training. The question is always asked by young people, why should you do scientific research? You're busy enough with your training, you have to read so many things, you have to learn about your profession. Why should you worry about science and publishing? I think there are numerous arguments why a young oncoming surgeon should participate in scientific research. First thing, when you do a trial yourself, you will learn a lot. Just preparing your trial, reading all the available literature, finding out what is already known and what is not known. This will greatly increase your knowledge. And my observation is that in many teaching institutions, I'm sure it's the same as here, there is an interesting material which has never been published about some special disease, about some special condition, about the special way they treat something which is already there. It is already there in the archives, but nobody has bothered to publish anything about it. Any publication which you make, it greatly increases your professional standing. Once you have published a couple of papers or presented material at the meeting, your professional status is higher. You are known as the thinking surgeon, and then you will be getting more patients, busy asking for consultations, and it will also increase, finally it will increase your income. And you have a chance to go to international meetings because the industry will sometimes support this travel, not only the university, and you might finally enter up as a participant in one of these trials. There are numerous trials about not only coronary surgery, about the drug treatment, whatever, and then you have opportunity to meet other people to get some support for your research. Numerous arguments exist for doing research work as a young surgeon. And to tell you the truth, you should not be disappointed if your first submissions, you send an abstract to a meeting and they don't get accepted. This is usual. When you look statistic of European Association of Cardiothoracic Surgery, abstract submission in the last year, 2012 and 2013, only 1 out of 5 abstract submitted was really selected. So selectivity is high. There are many of this, many are called, but few are chosen, as they say in the Bible. You see, 1 out of 5. That so at the beginning, don't be disappointed if you do not get accepted for publication. The strange fact is that the scientific activity is concentrated in relatively few countries. You're probably aware of that. When you look at the map of the world, that is how we know the world. If you now increase the size, you give each country a size according to the annual scientific output or the number of publications coming from this country, then the map of the world looks very different. This is United States, a huge amount of scientific output coming from United States, very big amount coming from United Kingdom, from England. For instance, France is quite big. My country, Switzerland, a very small country, but suddenly it becomes much bigger when you size the country according to a scientific research. And here, down here, Africa is a little small down, no scientific activity in Africa, and practically none in Southern America, only a little in Brazil. Huge Russian imperium becomes very small one in scientific productivity. So this is an interesting observation. You can find it in the internet, world map scientific output, and this comes up. And I find it changes every year, you know, the new one. And when you look, I now try to enlarge the Europe, you will see the map of Europe. The Italy is here, this is the Adriatics here. The Italy is quite big. Austria, which is also a small country, has a big scientific output. Germany, Netherlands, Belgium also, and France have an output. But when you look towards Black Sea, that is a very sad fact. For Bulgaria, this is just this tiny little place here. It is really insufficient. It should be done better. The Bulgaria, with the number of population, it is substantially bigger than Switzerland. But look at the size of Switzerland and Austria, the scientific output compared for this. So there is a place for improvement in Bulgaria. For instance, when you look, what should you publish? We have discussed it with Professor Panayotov several times. There are, for instance, a field of the so-called neglected ischemic disease. I see it when I travel in Russia, when I work in Croatia, where I started, helped to start a hospital near Zagreb. The coronary artery disease has very different manifestation there, because what you are dealing with and what you are observing is really a neglected coronary disease. And the patients are coming with a poorly treated hypertension, have the big hearts. They are having a cardiomegaly. They have a diffuse atherosclerosis because they haven't been subjected to statin. None of them is getting beta blockers before surgery. And so you have a different type of patient. There is a possibility to concentrate on this type of patient and find some interesting data which might be publishable. And you should remember that there is a place for scientific research coming from less developed countries. Our beginning for off-pump coronary surgery, OPCAP, came from less developed Southern American countries. The beginning was in Federico Benetti, it's published in 1991, first cases, and Ennio Buffalo had published it in 1996. Both this came from a almost third world, or much less developed name. It comes from Cardiovascular Surgical Center in Buenos Aires and the Scuola Paulista in Sao Paulo, with the two papers, and they really changed the face of the modern coronary surgery. There is a place for scientific work coming from lesser developed countries. The question is how to start. It's always when you have to write how to start. It's most difficult is the beginning. The worst thing, you have to analyze. You might have an interesting data. You have a result. We've been discussing, it's funny, that's exactly the same problem which we've been discussing in the car. You have a good results with a low operative mortality in the patients who have coronary artery bypass grafting, mitral valve repair in patients with a low ejection fraction. This kind of a patient is less commonly seen in Western Europe. How to do about that? You think you have a good results. My advice is first look carefully at your own results, if they are really so good as you think are. The surgeons normally neglect a continuous analysis. Look back 3 or 4 years to see if your results are so good as you think are. And then you have to adhere to these guidelines. I was busy in this committee, and we finally made the guidelines for reporting mortality and modality after cardiac interventions. And if you do not, you have to read these guidelines before you start any study, because it has exactly how you should report your data. And I will show you the mistakes you can do it. Excuse me. Reporting mortality in cardiac surgery. There are some things you should never use. For instance, you will find even now in some journals will be operative mortality. There is no such thing as operative mortality. Everybody thinks something different under operative mortality. Some people will mean it's perioperative death in the operating room. Some people say it is in ICU or in first 24 hours. There is no place for term operative mortality. This is wrong. It should be reported in accepted fashion. You should not report so-called hospital mortality. Hospital mortality can be really changed the way you want to have it, operative mortality. For instance, the patient is not doing well, you send him to another hospital, and if he dies there, he's not a hospital mortality. This is not the way to report scientific data. There is a famous example in the United States when they started obligatory reporting of the mortalities. And then it was hospital mortality. Several major hospitals in New York City have decided to have a part of their hospital will be hospice, coronary care. So you will have the Department of Cardiac Surgery, and on the left side of the corridor will be hospital, on the right side will be a hospice. If the patient is not doing well, they put him on the other side, no hospital mortality. That is the way how the mortality can be really skewed. And mortalities, it should be 30 days and 90 days, period, regardless where the mortality took place. The patient fell, died on the toilet at home, or the patient died in an ICU or in the operating room. 30 days mortality is a scientific way of reporting the data. And if you don't do that, it'll come back from the journal. If you submit to a journal, it has to be clearly decided. And funny, the paper I have shown you with we decided this definition of how to report data. It's continuously being mentioned in the data. I get it automatically update of my own literature citations, and it's every week. It is in some paper is published which is uses this definition. One should be careful about extraordinary results. They are suspicious to the editor, because everything is known about the mortality of valve surgery, coronary surgery, aortic aneurysm, and you suddenly come with the extraordinary results, 0 mortality in a series of patients. My reaction to it, that extraordinary results are usually matched not by how you operate, but what you do not operate. You know, you just have to refuse 2 or 3 patients per year and say, no, the risk is too high, and you have a very good mortality, the results are good. So this is not the true science. There are all tricks which can be done. A very famous American institution in the early times of cardiac surgery published a series of 100 mitral commissurotomies, consecutive 100 mitral commissurotomies without mortality. And a friend of mine was training at this famous institution. He swore to me the patient number 0 and the patient 101 died, but they took just this 100. It was truthful reporting, but it is still not truth in this. You can always find a segment of time where you had excellent results, and then you publish them. But this is not the truth. You should publish, let's say, a year from 85 to 95, okay, this, I accept this, there's a data, but not having at some stage, if they send me a paper, which in all patients were analyzed who were operated between 23rd of May of 2005 and 30th of September of 2010. There is a manipulation. It's quite obvious that you should not be taking fancy dates. It's obviously they have taken some patients out. The truth is found in American Statistic. Adult Cardiac Surgery in New York State, it is publication of 2016, I've just taken it out to have the new data, shows for every hospital in the United States, in the state of New York, they have the mortality, and they have shown, it's of course too small to read, but you have so-called observed mortality, the number of deaths, in the cases, observed mortality and expected mortality. Expected mortality is according to the risk analysis, which is known now, the risk analysis. And this is a risk. And then you get, for instance, you get a little star here. The Buffalo General Hospital had a observed mortality, which was a risk-adjusted mortality of 3.7%. They are doing less well than the rest of the New York State. And exactly the same statistic, can be found for surgeons. In every hospital, they publish the result for the surgeon. You find some well-known name, for instance, in Mount Sinai Hospital, Dave Adams, who is a big mitral surgeon, he has done in this 3-year period only 17 coronary cases in altogether. But he had a very good results. And there are some other, for instance, who will be doing a huge number of cases. Reddy did 306 cases and also has a very good mortality. These are with the 2 stars, it is better than the average mortality. So this is used for so-called benchmarking. If you think that your results are very good, compare them to the, for instance, data bank of Europe or New York State. In New York State, you can find a real benchmarking. What should be your results like today? What is them? I mentioned you analyzing your mortality and trying to change it, to modify it. Americans call it the gaming. For instance, when this obligatory analysis of the reporting of the results in the state of New York came, then the risk-adjusted mortality had the definition of chronic obstructive pulmonary disease, COPD. And the patient who had a COPD, of course, have a higher risk, and that it was considered they have almost double the risk of coronary surgery if they have a concerning obstructive disease. What happened suddenly in the next year, many more patients had suddenly chronic obstructive pulmonary disease. So you were allowed a bit higher mortality because they had to change the system afterwards. There is now a strict definition of COPD, but it was used for gaming. The trick is of transferring the patient with postoperative complication. Nowadays it is tracked in state of New York, but if you send him out of state of New York, then it will not be tracked. It will be lost to statistics. And then what has happened is and this is really bad, that patients who are at higher risk have difficulties finding a surgeon. 82-year-old person with a three-vessel coronary disease and aortic stenosis and some mitral incompetence, you have to look very hard in New York City to find a surgeon who will be willing to operate it. He doesn't want to spoil his mortality statistics. And finally it ended sending difficult cases to other states. There is a proof. It's an interesting paper which was published from Cleveland Clinic in 1996. They analyzed the data. Their mortalities coming, the patients, some come from other states, not only from Ohio, but from other states. Then suddenly, until 1988, before obligatory reporting of the mortalities came about, they had about the same mortality. Since 1989, mortality of the patients from New York, state of New York, was 3 times higher. Obviously, they were sending their bad patients to Cleveland and to be operated there because surgeons didn't want to have bad mortality themselves. This is so, always read it with in Latin says cum grano salis. There are some topics which you try to avoid to publish. For instance, standard operating procedures. You might have an excellent result, coronary bypass grafting with a 0.5% mortality, aortic valve surgery with less than 2% mortality. It will hardly be, it will never enter a major European meeting or there. Everything is known about this statistics, and so this should be presented at the local meeting. It's necessary. In the local meeting, it is very important. The people who are sending a patient should know what the results are. Here, in St. Mary's Hospital, you want to have they should know the data, they will know the risk, they can tell the patient a risk that they have. So there is a necessity presenting at local meeting, but don't try to go to the European Association meeting. Then you present a solution, suddenly you say, let's say adding a piece of pericardium to the anterior and posterior leaflet. It's, okay, let's go to European Association meeting. No use. It has been published 25 years ago already, and everything is known about it. Don't try to reinvent the wheel, what is called. Small series of patients, less than 10 or 20 patients, they will never be published because it is, again, a local paper or something, yes, but anything which is reached in a series of 10 patients can be due to chance. You have seen the statistical calculations. The non-existent or very short follow-up, you have done excellent results. I have acute aortic dissection. I have 50 patients with acute aortic dissection type A, and I have only 1 death case. It's excellent. The patient went home. But what happened after 2 months? The mortality of this kind of procedure is very high. After successful operation for type A, there is a first-year mortality of about 20 to 25%. That is a fact of life. It's well known in statistics. So short or inexistent follow-up is a chance, you don't have a chance to be accepted for the presentation. And the obvious pre-selection of patients, and then the very common mistake, repetitive presentation of the same material. You did very well presented 2 years ago with, again, mitral valve surgery with a poor ventricular function, very good results in 60 patients. And then you have 70 patients, you still have a good result, you want to bring it again. This is not a new publication, and it will be refused because there is no new material involved. careful study of literature is one of the most important things. We all have an access now to scientific databases, and you use either the Medline or the Ovid or PubMed or HighWirePress. The problem becomes that you get too much material out. You look, for instance, again, in a surgery of acute type A dissection in the last 3 years, and a huge number of reports come out in diagnostic, surgery, medical treatment, whatever. But you get a huge number of literature citations, how to select those, how to have it in a material which can be used. For instance, let's use an example. In Ovid databank, search mitral valve repair, coronary artery bypass grafting in patient with a poor left ventricular function. And what I use first is the so-called Boolean logic. You know, you take a group and you say "and." Two different things, I put "and," and suddenly you have much less patients. And then you use a full text. They require full text, year of publication. You want the new publications, English language, and review article. So example is, I take coronary artery bypass grafting, it have 49,000 citations, and take a limit to 2,000 until current, and have 28,000. I take mitral valve insufficiency or mitral repair, have 21,000, I reduce it to 2,000 until now, the 10,000. I take, that's a Boolean logic, I take 2 and 4 together, and then I have the patients until 2,000, both with the coronary bypass grafting and the mitral valve insufficiency. There are 640. There are too many to read. 640 publications you cannot read. But when you go here, ventricular dysfunction, a huge number of ventricular dysfunction. Take a ventricular dysfunction and then put it with this 640, and you have 129. It is still too much. 129, it will take you a couple of days to read all this material, 129. But if you take here, you limit it to to review articles, suddenly you have only 3 articles. This is something you can look at it, and this will quickly lead you to the important information. And now the results, there are only 3 literature quotations. I decide to use the last one, and I open it because I know the authors, and then I get a very good overview, advanced surgical treatment in heart failure. And not only that I have the good results, the literature give citing articles which have been citing this particular article. So you automatically go into the newer literature. It'll just show by itself. The computer gives you out the newest publication about it. And then you go into this, you find a couple of these articles which have been taken. You go to the article itself. It is in PubMed. You can get it in a full text, because nowadays most of them are available in full text. And if you go through the PubMed will again, give you the newest article which have been which are quoting this particular article. So that is how you go to the newest articles about the problem, and you are not swamped with the hundreds of literature citations. And there is a trick, you have to learn it, but after done it a couple of times, it is done fairly easily. When you submit a paper, you must know what the editor thinks about. He will first ask, is it a consecutive series of patients? It has to be stated in text. 100 patients, 100 consecutive patients from 2012 to 2013. If it is not in there, editor, it will come back to you with a question. Editor will ask you if it is a consecutive series. Then the editor will ask, are all patients involved, or is there a selection patients for this procedure? So there is somebody, you can select the patients who will be doing well, and the selection criteria should be placed. And when you start preparing a scientific study, you have this sample size. We spoke about it, number of patients necessary to detect the difference. If there are small differences, 2 and 5%, that's a surprisingly large number of patients necessary. This is a table which shows the degree of difference. If you have a 50% of difference, of course, you can do it with less than 50 patients. But the smaller the difference, let's say 20% of difference, you need about 200 patients in each group to find the statistical difference. For instance, 200 patients, 30 days survival of 90%, and the other group is 95%. 200 patients in each group. Difference is 5%. Is it significant? Who thinks it's a significant difference? It is not. When you calculate it, and the P is 0.058. If there are 300 in each group, then it will be a significant difference. This is in computer within a minute. Just put the numbers in there, and there is a calculator of significance that does automatically for you. You don't have to think about it. Basic knowledge is necessary. Who knows what a type 1 and type error is? What is a type 1 statistical error? It comes all the time. When you read a result, it's we want to avoid type 1 error, and therefore we did it this way. Type 1 is one is false positive, one is false negative. This is the way to think, and I found it in the internet. Type 1 error is a false positive, and type 2 error is the false negative. That's if you remember these pictures, you will know always what the type 1 and type 2 statistical error is. And then one should not automatically trust everything which computer has calculated. This is one of my favorite articles, and it is very old. It comes from 1980. It was written by Kerry Lee, who was a chief statistical consultant and in Duke University Medical Center. And Duke had already then time put all their patients in a statistical database. And he has examined 1,073 consecutive medically treated patients with a 3-vessel disease. And this group, he has let the computer make 2 groups. The group don't exist. He let the computer, just by statistical chance, put one in a group 1 and put the other patient in group 2. Same treatment, same group of patients. There was no difference with them. And then he has taken of these 2 groups and made a subgroup of the so-called treatment A and treatment B, and suddenly there is statistical difference. But there is none. Statistical difference, but it shows the weakness. Then you have small groups and sub-analyzing the small groups. He have found a statistical difference, but there is absolutely no difference. Same patients, same people, but just putting them artificially in various groups. It's a coronary artery disease, computer assigned in these 2 groups. Substantial difference is there. There, I've shown you the perfect correlation here with the lemon impacts and highway death. And there is one trick which editors react seriously. This, when you look at these 2 curves, it's not about medicine, it's customer behavior under 40 and over 40 years of age. It looks, they are very similar behavior. The curves are very similar. What you don't notice in the first, that they are on a different time scale. This is 35,000 and this is 500,000 scale. When you draw them on a true scale, then it looks like this. And this is a trick. You have to watch always both sides of the curve. When the curve is published, the left and right abscissa, you compare them. It must be the same. It's a very instructive example how the data can look differently. When this looks like this first, but then you put it on the same level, and then it looks totally different. Then you have to read, of course, simple rules. I can tell you, as the editor, the rule number 1, you must be short. Don't try to say everything what is on your mind. A paper, publishing a journal, is expensive business. I can tell you that for European Association, 1 single page of European Journal of Cardiothoracic Surgery costs us about 800 euros. And this is expensive. You know, the journal doesn't support itself. The European Association has to pay for the journal, and this is what we invest. But editor is under pressure, because editor is given every year, is given certain number of pages. For instance, when I was there, I had available, finally increased it to about 1,200 pages. Now it is 2,500 pages for Francis Beiersdorf. But he has to stay with the old material, has to stay under 2,500 pages, because it is expensive. So don't be long. When you're writing a paper, be concise. Introduction should be not more than 3 or 4 sentences. When you say as short as possible, but staying clearly why you wanted to do it and how you did it. That is introduction. Then one very common error, especially that happens with a computer, with the copy and paste, you copy the sentences from the introduction and you put it back in the discussion section of the paper. It is something that editors are allergic to, because it just inflates your paper. Paper should be short, as short as possible, to be clear. One error which people always make, and I have to send them paper, never publish the same results in a table and then again put them in text. You have a table with the age of the patient and the results of this, and then you start writing sentences. As the table 1 shows, there is a higher mortality if there is a patient above 85-year-old and less mortality than 70. It's no use writing it in text. It is already there in the table. So avoid repetition. That is the reason why the paper goes back to the authors. Never same results in the text and in tables. And abbreviations, as few as possible. Especially Japanese, they love abbreviations. It's all this CV, CI, PTCA, okay, this is accepted. But some people love abbreviations and it becomes very difficult to read. Of course, you have to use a statistical consultant. One of the very common errors that people like to give the groups. I have a group A and a group B and a group C. And you turn the page or the next slide comes and you don't know what is a group A or what is a group B. Why not say the group off-pump surgery and on-pump surgery? So these are clearly defined groups. But group 1 or group 2, when you listen to the talk or you read that, then you have to turn the pages back to see what he means with the group A and group B. And this is what the editors also criticize. Don't say that this is just excellent results which we reached. You have to compare it to the literature. And this is the really sense of the discussion. You have done something, you had a good result, you have to compare it to what is already known about this subject, and that is the discussion. And then usually it's a very good policy when you're writing anything. The last 2 or 3 sentences, you make a small subtitle and then you call it conclusions, because people don't have time to read the whole thing, but they will go to the conclusion and say, now this is the message. You should never do mitral valve repair in a patient above 85 years old or something. This is the message and you should do it, and this is the little subtitle. And one of the things I can tell you where the editor will throw out paper automatically is if you make spelling mistakes. Today it is unacceptable to have submit a manuscript with a lot of spelling mistakes. Exactly the same for the abstract. This will go back immediately. Don't even enter the deliberation of the consultants. Spelling check must be done and must be perfect. If it is not perfect, the paper goes back. It means that it was carelessly prepared. You didn't pay attention to the details. And this is abbreviation. That is, I got it from my colleague, Dr. Vage, Chief of Surgery in Oslo. It's, for instance, you write a sentence, cardioplegia C is a type of ischemia reperfusion injury, IR, connected with hypothermia, H, IR causes myocardial stunning, MS. MS occurring after IR has been extensively investigated, metabolic consequences and gene programs activated. And then the next sentence goes, the role of MCGP and AIS in C-induced IR is not fully known. So, but it can be on the next page. You have to go back the whole thing. Avoid abbreviations, because they are CABG for coronary artery bypass grafting, okay. Aortic valve replacement, AVR, that is okay. PCI, percutaneous coronary intervention. TAVI, transcatheter aortic valve intervention. But this, something like this, and it happens all the time. People, especially Japanese, they love this. It's full of this shortening. I don't know why they like it so much. And then an advice of the editor, watch your numbers. It so often happens. For instance, it's from a paper which was submitted. All patients alive, number 16, were transferred to rehabilitation. After 6 months, paravalvular regurgitation was trivial in 16 patients and mild in 1 patient. Suddenly there are 17 patients. And remember he said it was 16. It happens when you, several times you write the paper and you decide this I will not quote, but then it comes here. And this goes automatically back if you have a mistake. So it is very good policy is to have a friend read this before you send it out, because losing face, you know, then it was rejected. For instance, don't use strange words. For instance, for another paper which crossed my desk, stenosis was evaluated not iodinous. What is iodinous? I had to go in internet. Does somebody know what is iodinous in Latin? It is iodinous is suitable. It comes from Latin, but nobody uses this word. It is obviously an Italian paper, and for them it was much easier to write this. So be careful what you write. Again, spelling check would have detected this. Again, strange abbreviations from a paper. Pacemaker was implanted because of BAV3. What is BAV? And what is a BAV? Who knows? Who speaks Italian here? It's a blocco atrioventriculare, AV block. And then one ventricular fibrillation was solved after BLSD. What is a BLSD? And had a hemetic transfusion. BLSD is for the basic life support defibrillator. Nobody uses it, but for them in their hospital this seems to be abbreviation when they use. Don't use it in a paper. This paper went back also. And there are formal reasons. If you have a careless preparation, obvious duplication in text, too many words. European Association says manuscript, including tables and literature and text for illustration, should be less than 5,000 words. And suddenly comes 6,500 words with a personal letter of the author, the editor. It's very important. He knows that it's too much, but it's extremely important this is published. Goes back, and the rules are valid for everybody. Plagiarism is a very serious offense. I told you that it happens again and again. Inaccurate or false literature citation. Sometimes we do in editorial office a spot check on literature citation, because it will come also in this automatic scanning of the document, that it will show that suddenly that it is not true. It's easy to make these mistakes by copy and paste, and suddenly the numbers get wrong. So check literature citations. Poor English is the reason for sending the paper back, because it is not the duty of the editor, editorial staff, or the publisher, Oxford University Press, to rewrite your paper. You have to do it yourself. If the English is poor, it goes back. Goes back with the advice that you should use a native English speaker for writing the paper. You can always find somebody who will help you with this. Incorrect numbers, you know, in text is one number, in the table is another number. Very common mistake, surprisingly. False calculations, wrong percentages happens on it. Every manuscript is checked first in editorial office by the trained staff. And if there are any formal errors, the manuscript will never go to the editor and never go to the reviewer. They will just send it back because it is not done according to the rules. And plagiarism, we have shown you that the plagiarists somehow never learn. Always, every year, there are new who try to steal the data, to manufacture the data. It always comes out. It comes out in the same way. When people send you some data which are excellent, and then 1 year later or 2 years later, somebody who was fired from this department goes to the editor and tells him, listen, this is not true at all. This data, the patients died and they have transferred it somewhere else. That paper is not true. The editor writes to the author and said, there is a serious doubt about the data. Can you provide me with original data? You can, or he sends somebody to check there. And then the whole thing comes out. As a rule, every plagiarism comes out after a while. And then it's terrible for the patient. Duplicate publication is something which we hate, but I will jump it, it's too far. What editors hate is so-called Parma manuscript, very thinly sliced. You have a material and then methodology, you write a paper. And selection of patients, you write another paper, and the results, you write a third paper. It happens even in the United States. The syntax trial, the methodology of syntax trial was published 2 times before any patient was done at all. It was already a publication. Now, this is called the Parma manuscript, or a salami publication, very thin slices. Try to put everything in your publication, because it inflates the publication list, but it's detected, and you come in blacklist. Every editor has a blacklist of authors who has sometimes done an error. Something like this is also brings you on a blacklist, and this particular editor, a particular journal, will not publish your work anymore. The one question about the authorship, it makes so much problems, not only for the editor, but in the units. All the authors should comply to the following rules. All the following: made a substantial contribution, participated in drafting or revising it, gave final approval. All the 3 conditions should be met for somebody to qualify as the author. I have seen so many major problems arising in a unit after they sent a paper somewhere, it was published, and suddenly somebody writes to the editor, hey, listen, I did 80% of the surgeries there and I'm not as the author there. Or I did all the calculation and gathered data, I'm not the author. And then an unpleasant letter goes to the first author and to a senior author. Settle all the authorship problems before you send it out for presentation or to a journal. It should be known. And the rule is that the first author is the one who has performed most of the work and wrote the manuscript. And the last author is to be originator of hypothesis of the chief of the unit. He really conducts and controls all the work. And having treated some of the patients does not qualify you for authorship. That is something which is not known. People think they have treated, they have done 20 patients with this series of aortic valve replacement, they should be authors. It's not at all. It is only the people who really did the research work on there. For instance, I've been recently, a paper crossed my desk, and these are my comments which I wrote, assessment. Manuscript has been prepared carelessly. Numerous spelling errors, and I quote them. I copy and I quote them errors. For instance, patient presenting with type A aortic is actually present once more. Outcome with this strategy in this clinical setting are. It is no spelling check has been done, and then I object to this. Difficulties with table 1. There are 39 patients total, and then suddenly if you analyze the surgery, TIVAR, ECMO, where are the last 2? They got lost somewhere. So you must be very careful when you're submitting. This is somebody in one of the reviewers will find it out. And then the general comment, calculating percentages in small number of patients, it makes no sense. For instance, calculating 15.4% out of 6 patients is a joke. You just put the number, 1 out of 6, period. And that is something, again, which is not done. I have put here, and this is going to be late, I have put here the whole series of papers which have been submitted to our meetings and which are either accepted or refused. I think it makes no sense. I send it, everybody is getting tired now, but you can copy this from the computer afterwards. You can copy and look at yourself some of this. I'm showing this patient papers which are not accepted for presentation. For instance, from the meeting post-traumatic aneurysm of the aortic isthmus, 2 cases. And then he goes, and they are done in 2 patients, and 2 patients, 29 and 43-year-old, they're treated by distal aortic perversion, whatever. Now, how do you expect to publish 2 cases of anything? And there is also not a good follow-up, but there is really nothing new in this that gets rejected. The other one is study of study of predictive factors of mortality for patients after coronary bypass surgery. this is a data mining. Somebody has taken data from the hospital database, and he reached some calculations show you that a prolonged surgery, type of surgery, post-operative pneumonia are the risk factor for death. This is not science. It is just data collection. And this doesn't get accepted. There was no idea. I did this because I want to see if post-operative pneumonia is the cause of death or not. It is just data mining. They taken all the data from the computer and something came out, and that is published. This is not good to be publishing. Something which gets published is, for instance, a paper like this, the real-world transcatheter aortic valve implantation, and it has been systematic review and meta-analysis of European TAVI registries. And there were TAVI registries in 7 European nations, and they found 9,860 patients. This is a strong paper. This is the statement, and they find something. It is from several nations. It's a big group of patients, and papers like this get automatically accepted. There is, for instance, pediatric mechanical circulatory support with Berlin Heart. And again, they collected 115 children with the different LVAD, biventricular assist device. And this is an important paper. It is this data which should be followed. We find from this data whom not to put on assist device and whom we should use assist device. This was accepted. And now, and this goes too far, it'll be too long, I'm afraid. New EACTS, you submit not an abstract as now with 250 words. You submit a short PowerPoint presentation, 6 PowerPoint slides, which is very good for the reviewers. When you have to read it, when you have to read all this small print, it becomes difficult. When you look at the PowerPoint presentation, you can very quickly go through this. And each one has to be the short PowerPoint. I think it is 6 or 8 PowerPoint slides are now. Surgery for aortic endocarditis. Mortality and prediction, about 131. It's bad English, about 131 patients in title. But again, they find they did 131 patients, surgery for aortic endocarditis. Then again, it is a usual error. Middle age is 38.96. You cannot 9.96. What is 0.06 year? So you always bear what is data is measured. So it means it's 39 years. And, but it goes on and on. I'm showing 83% of the patient a characteristic lesion of infective endocarditis. But they say they are analyzing patients with infective endocarditis in title, and now there are only 83 had infective endocarditis. Hey, listen, something is not correct here. And then it goes, you see a number of spelling errors, emergency double M, hemodynamic embolic complication, interested. What does it mean, the emergency surgery interested? It means the patients were subjected to emergency surgery. And hospital mortality, again, what is 0.45 patient difference? Elective surgery is 6.81. But what they find out, finally, the operative risk is improved by early diagnosis and medical treatment. There is no word whatsoever in this abstract about early diagnosis. Nothing goes in there, and no word about the medical treatment. In our serious hospital, mortality is more frequent in emergency surgery. It was not in the text. Aortic endocarditis prophylaxis remains the best solution. In the whole abstract, it is not a word about the prophylaxis. And suddenly it becomes his conclusion. The conclusions must reflect the text of your abstract and not some generalities like this. So this aortic coarctation, about 67 cases. We describe, look at the spelling error here, we describe in this point, it should not, this should not happen really. They did, in a 67 patient, they did a coarctation surgery, the different operations, only 0.1 patient, it's one patient I mean. And coarctation is generally diagnosed at birth. It doesn't come out from this paper. But that is, coarctation of aorta can cause high blood pressure. So this is, you learn in the medical study that it causes high blood pressure. interest of early diagnosis. There is nothing in this abstract that early diagnosis must be different. They don't describe it, so don't put conclusions which are not based on the data you did yourself. So it was rejected, especially what is new about the surgery of coarctasia. And then there is an excellent paper, predictor of left ventricular recovery, in surgery for AI, and they went to the large group of patients they included, and finally they find in a series of patients, they find in this very advanced risk analysis that the intervention, the left ventricular systolic dimensions are important predictor of a success. So it's an argument for early surgery, and this gets accepted. So publication from a small unit, summary, is still possible. Retrospective analysis can deliver interesting material because you have a different material from the rest. Again, working with a statistician is essential. You should use longer observation time. The longer the observation time, the better is the chance that your manuscript will be accepted or your abstract will be accepted for presentation. The quality of data, the way you analyzed and the way you analyzed your patient, it determines the success of publication. And that is a couple of remarks about it. Thank you.